Hi, I'm Dr. Dan Rubin with Ad Hoc with a Doc. I have the privilege of being here with Dr. Jeanne Stryker from Solana Beach, California. Dr. Stryker is not only a retired major from the U.S. Army. Thank you very much for everything you've done, not only on behalf of our country in the United States, but what you've done on behalf of patient and patient care and how you are advancing therapeutics for people with cancer, which is really our subject today. When we first got to know each other, we had talked a little bit about the role of circulating tumor cells in disease. And then you were telling me about your practice and the role of cryotherapy. And I just was so anxious to really sit and spend some time with you. So thank you for being here. And thank you for coming into Scottsdale.
Well, thank you for having me, because I think we've got a lot in common working together for the patient.
You, as an interventional radiologist, actually, for the audience, what really even is interventional radiology?
So interventional radiology is basically using imaging guidance to get into different tubular structures in the body.
So like X-rays is an image? That
right.
Kind of, or like a CAT scan?
So CAT scan, MRI, ultrasound, or X-rays. So we're either manipulating electrons, or we're manipulating sound waves, or we're manipulating protons
to see things inside the body.
Right, and you're seeing it today on like a computer screen or a TV screen. So we're able to look inside the body, and I can drive either a wire and a catheter to get to any tubular. I say tubular structure because it's not just an artery or a vein. It could be a bile duct. It can be, the renal system is tubular also.
So tubular, like an artery, is a tube where blood flows through.
Correct.
Right. So you can put something into there to get to your target tissue.
Correct.
And why would you do that?
Well, when we think about cancer and what feeds cancer, I mean, obviously you have to have oxygen in order to survive, and various nutrients. So we go directly into the artery versus systemic IV therapy, which is in a vein. We're going to the artery that's feeding the tumor and depositing a small amount of either chemotherapy or immunotherapy. So it's getting right into the center portion of the tumor, and then we're cutting off the blood supply with various particles that are micron in size. And then I always say to patients using platinum coils that kind of lock the door. You just said a whole heck of a lot. And I know for the audience out there, some of them may not understand exactly what that was. So you're saying that you're looking at what artery is the blood supply for a certain tumor. Correct. Let's take a tumor, say, in the kidney or the liver, or what's fair? Well, honestly, we started out with the liver. As we spoke earlier, the liver tends to regenerate. So why did we go into liver? Probably less damage. We know that either you have a primary, means that it began in the liver, or secondary, it came from another organ system, such as the colon. So we could go into the arteries in the liver. Either, we originate in the groin artery. And I always explain to patients, it's like, if you think about a trunk of a tree and then the branches, so we go into the root at the trunk of the tree, and then we can go in any part of the main trunk, or we can go into the branches that feed the various organ systems. So if the tree had a cancer, and that cancer was located past the trunk, past the next tree, past the next branch, past the next branch, like here. Correct. If this was a cancer cell or a cancer tumor, you could actually use the groin vessel and advance a wire all the way so that you could put a medicine into this cancer tumor right here. That's right. So we use a wire first. The wire doesn't stay in the body, but we're using that wire because it has a lot of, I'm able to move it, to steer it better. And then over the wire, we put a small catheter. So then we pull the wire out, and we can inject dye that will outline this branch right here. So a catheter is like a little hose that allows you to deliver. Yes. Okay. And we use a bigger catheter to get in here, and then we use a smaller catheter to get down here. Okay? And we use a smaller wire to steer as well. It's like a reverse telescope? Well, actually, what I call it is road mapping.
Okay.
So when you have a wire, it's black on the TV screen, and the dye is black. So how am I going to know where I am if I have a wire that's black on black?
Okay.
So we call it road mapping, where we invert the dye is now white, so that I can see that black wire go through the roadway. Because I don't want to be over here. If the cancer's not here and it's over here, I want to make sure that when I inject dye,
You're getting right there.
I'm getting right there, and it has a really typical appearance that we call like a blush. It's a tumor blush. So it's very typical for us, visually, and we know we're in the correct spot. And one of the other things I'm
going to stop you there for one sec. You said, I want to make sure I'm in the correct spot. So for the audience, this is very different than, say, getting intravenous, even though this is in an artery.
Right.
So it's in the circulatory system. You're putting it directly, literally onto or into the cancer cells. Whereas if somebody goes for chemotherapy through their arm or through their port, it's pretty much going into the wild, maybe starting
Correct.
here, and you hope some gets delivered here.
Right.
Some may get delivered to the healthy cells. So that's what you're doing is very different.
Yes.
And what's that process called?
It's called embolization.
Okay.
So basically it just means we're blocking the arterial supply.
And so you may then take a medicament, and it could be chemotherapy, which can directly kill cancer cells. It could be immunotherapy,
Correct.
which can cause or initiate an immune response against those cancer cells, or something else, and you can put it there. And then you talked about locking it in. How do you do that?
So again, using X-ray guidance, we can put coils in, and they're made out of platinum.
So an actual metal piece.
Correct.
And that blocks the vein then, or blocks the artery?
Blocks the artery.
Okay.
Yes.
Which means that no more healthy blood can flow into that tumor.
That's true, but there's a fine line. So
Okay.
you want to make sure that you're getting that tumor completely killed, because the cancer I like to think of it has its own brain.
Okay.
So
Yeah, talk to us
it
about that.
knows that it's dying. So it's going to do whatever it can to stay alive. So if that means it's going to recruit from another blood vessel, it will. It'll do anything it can to stay
it'll try
alive.
and get blood from somewhere else.
Right.
Got it.
And I was telling the story earlier. I had a right lung tumor. And
You did, or you had a patient with
I had a patient with a right lung tumor. And so, you would think the bronchial artery feeds the lungs, so it's going to be coming off a bronchial artery. What happened is my catheter fell into an artery on the left side, and I'm like, let me inject that. So I injected it, and I said, that's the left adrenal artery. So when I was injecting it, I saw this filling, and it crossed the midline and went all the way up and was feeding
Wow.
the tumor. And this is what I'm saying.
That was unexpected.
It was unexpected.
Is that normal anatomy?
I would have been in there for hours trying to find the bronchial artery feeding it. And this is when I decided I'm going to do what we call a CTA, which stands for CAT scan arteriogram, so that in advance I can determine what blood vessels are actually feeding the tumor.
Okay.
So I'm not on a scavenger hunt for a couple hours. Right,
Yeah.
exactly. Patients under, you're exposed to radiation and whatnot, and you want to get in and get out. But you want to do the job correctly.
You're in there, you're in the body. You are essentially using radiology, because you're a radiologist.
Correct.
And a radiologist uses, like you said, X-ray techniques or CAT scans to look at the anatomy and to look for disease or normal structures. And then you're taking it a step further. You're actually doing procedure-based therapeutics to use your radiology background, find exactly where you want to go, and you can get into these nooks and crannies of the body and deliver medicine or whatever treatment it is right to there.
Correct.
It's fascinating. And I know our audience is going to be fascinated because it doesn't kill the good cells as well.
No.
And so many people out there we hear them talk about, I might not want to do this treatment because doesn't it kill the good cells? Or if I get radiation and it's really close to my heart, per se, or what if, I don't want to get, if they're getting like a colon cancer radiated or a pancreatic cancer radiated, there is side effects to that because the radiation
Absolutely.
has those effects. And so that's embolization. Basically putting something into a tumor, locking it so it can't get out, nothing else can really get in, and so the treatment's right there, and then the idea is that the cancer tumor dies.
Correct.
What happens after that? Does the body resorb it somehow?
So yes, it will. The body has a great ability. It's part of the white blood cells immune system. It'll come in. You have those, I always say, like little Pac-Men. They're macrophages that come in and start to eat away at the dead debris. And it happens over time. But I've developed a protocol where I'll go in with the embolization because I want to cut off the blood supply to the tumor, allow it to decrease in size, and then if I can safely go in and then perform cryoablation.
Cryoablation. What does that word actually mean?
So cryo is cold, and ablation is you're basically killing something. So it's either heat-based or it's cold-based.
Okay.
So heat-based is radiofrequency or microwave.
Okay.
Cryotherapy is cold-based. And I know you're going to ask me the question, so why do you use cryoablation versus radiofrequency or microwave? Because cryoablation is that ablative therapy that sets off an alarm to the immune system.
Okay.
I like the fact that there's immunotherapy associated with cryoablation. Radiofrequency is going to be pretty much passé as we move into
Meaning
more.
It's an older type of
It's
technique.
an older type of therapy, and also, with radiofrequency, you have something called heat sink.
Okay.
So you have to be careful because you can get close to either an artery, a vein, or any other vital structure, and you there's so much intense heat that you can cause damage. Damage to the tumor, but you can also cause internal damage to other vital structures.
And if you have a vital structure like a nerve, somebody could lose function of whatever that nerve is innervating. If it's a major vessel, they could perhaps bleed out.
They could bleed out.
Die.
The good news is, as an interventional radiologist, they call on us in a setting of trauma. So if they bled out, I could quickly get into the artery and cut off the blood supply, but that's not really in good form to do something like that.
And just to explain, radio frequency is using some type of, it's a frequency.
Correct.
Radio doesn't mean like, oh, we're listening to the radio and tuning in on sports. It means that there's a certain sound wave frequency. And some of those can be toxic to cells. Just like if you...
Absolutely.
Okay. And that is a therapy, and I've referred for that for some of my patients. But there's cryotherapy. Is it newer or older than radiofrequency?
So cryotherapy's been around for 20 to 30 years. We started out using cryotherapy with renal cell carcinoma.
That's kidney cancer, right?
Kidney cancer and liver cancer. And then we've evolved into the lung, the bone, breast, prostate. I've even done pancreas and soft tissue tumors. So a tumor that's either in the pelvis or the abdomen, that can either be on the skin or it's within the space in the abdomen between an organ system or pelvis.
Now, I want to ask a question about why cryo versus something else. And then I really do want us to have a discussion about how the immune system, which you brought up a little bit ago, interacts with cryotherapy and why it's so important. Some people may watch this video and ask, is cryotherapy a safe alternative to surgery? Would cryotherapy be a therapy for somebody who may not be a surgical candidate? And so what are some of the reasons why? Is it cryo versus surgery? Is it cryo because you can't have surgery? Or is it a mix of both clinically?
Really, it's a mix of both. So number one is if you're not a surgical candidate, based on other comorbidities, in other words, diabetic, hypertension out of control, and just other organ systems that are not going to, it'd be more dangerous to do surgery.
Meaning to
like general anesthesia and putting somebody under, somebody who has COPD, so chronic lung disease. It's going to be harder to get them off of general anesthesia, or they have some kind of heart condition. So they wouldn't really be a surgical candidate.
Okay.
But the other thing is that it gives the patient another option. So it's another tier in oncology, because we typically talk about surgery, radiation, and chemotherapy, but cryoablation and interventional oncology is really another tier for patients to choose from. It's minimally invasive, it has less side effects, and most of the procedures I do are outpatient.
Wow. And are they under anesthesia?
I work at a surgery center in hospital settings, so a lot of times it's easier to either, you can do conscious sedation, which means you're getting an IV of like IV Valium, but it's called Versed, so it's a short-acting benzodiazepine, or fentanyl, which is a short-acting morphine. What happens is a patient you're really relaxed, so you tend to fall asleep.
Okay.
But it's nice if
is it like a twilight type anesthesia?
Yeah, it's like a twilight, but we can also do, like propofol. So I don't monitor the patient, the anesthesiologist or nurse anesthetist does. So I'm able to really do my job and focus.
Yeah, so it's not done just in a typical office. This is a true procedure.
No.
This is in a hospital or in a surgery center.
In a surgery center, yes.
Very good. Now, cryoablation activates the immune system. In two ways, and you had mentioned this, that the immune system responds to the actual temperature. The decrease in temperature, the coldness. But as the ice ball begins to melt, and as those cancer cells are dying, you have the cancer cell breaking up and exposing parts of itself that weren't really seeable by the immune system. We call these antigens.
Correct.
And these are little teeny pieces of the tumor that the immune system can recognize and respond to. And so not only is the immune system activated by the cold, but then there's something there for it to do. It can find something.
Well, yeah, and I always say there's a two-part. So what happens with cancer, as I said before, it has a brain of its own. So what does it do? It creates kind of an invisible shield. When people say, how come my immune system let me down? Well, because it created an invisible shield. So number one, you're creating trauma.
Okay.
And so now it's like, wait, there's something going on in the body. And then the white blood cells, which is part of the immune system, wakes up. Now, we don't know. Sometimes our immune system has let us down. Our T cells are not as effective as they could be.
Is that because of other comorbidities, diet, maybe lack of exercise, toxins in the environment, genetics? Is there a host of things?
I think a lot of it has to do really with the epigenetics. So we talk about the genetic component, but also how our genes interact with the environment. Okay. Because a lot of times what happens is these genes are they're kind of quiet. We know we may have that propensity for this disease, but it gets turned off. Or it gets turned on. So there's certain genes that should remain off, they get turned on, and then others that were supposed to be turned on get turned off. So they're like vice versa, they're not doing their job. And I mean, it can be, I believe a lot of it now has to do with the environment. There's a lot of toxicity today that we didn't have before. The cancer rate is rising. I've heard that even 50% of our population is succumbing to cancer. And we didn't have that before. And I don't really believe it has to do with our ability to detect cancer imaging, because if it was, it wouldn't really change.
That would make sense.
Right.
And so back to the immune system, you're saying that sometimes the immune system has failed us, or somewhere along the lines the cancer outsmarted it or took advantage or exploited that. But cryotherapy is in favor of the immune system.
It's in favor of the immune system because, again, you're creating that danger signal. But then when you freeze it, you're freezing it to 40 degrees below zero.
Wow.
So, I mean, what can live in 40 degrees below zero? I always get the patients to laugh a little bit, and I say, maybe a cockroach, But other than that, so it doesn't live.
Right.
And so we do a dual freeze. So we freeze and, so you've got the tissue frozen to 40 degrees below zero. and then we do a thaw time for about 8 to 10 minutes, depending on what organ system. So then what happens with that, as it's thawing out, you have a cellular explosion of those contents within the tumor cells. So those tumor antigens are released, and all the other cytokines that are associated with it that get out into the bloodstream. And then we freeze again just to make sure we got it. But what happens with the second freeze is the ice ball becomes larger in size.
Well, it's amazing because so often we've tried to give IVs or supplements or chemo or whatever it is, or radiation to try and get the cancer cell to die. But in so many instances, it also negatively impacts the immune system. So even though you have exposure via that explosion of the tumor cell-based contents, there's nothing there to recognize it. Or maybe the immune system has a wall that it can't get through, like that invisible cloak. But this time it might be put out there by a medicine. So this avoids that, which is why when we've talked about this, and you and I have shared a couple patients, we were able to really put together an immune-based protocol that we've had patients use before cryotherapy.
That's right.
The idea is that if they have the cancer, and if they're immunocompromised, and what I mean by immunocompromised is the cancer grew and they're not reacting to the tumor,
right,
then it makes a difference for us to hop up the immune system, to get it activated. And so many people out there know what it means and read about the immune system and how that's your first and last defense against cancer. So we developed a 3-week protocol to use before cryotherapy. It's a lifestyle-based program. We have some IV therapies, some repurposed prescriptions, injectable therapies, and some supplements. And then the idea is get people hopped up and then go get cryotherapy. And you really have the ability, once you get cryotherapy, to have a lasting immunity against the cancer. Now, what you had said about the patient where you've done cryotherapy, you've done embolization, you came back and did cryotherapy, that sounds a lot like what I tell patients about a reasonable biologic pace. Now, there's a pace we can expect. Things don't just go away, quickly. Like if you have a decrease in the tumor marker and a shrinkage of the tumor, some people expect things to happen super quickly, and why isn't it happening fast enough? And you and I will look at the labs and we'll explain it to them and say, well, look at this trend. Look at this overview. Things are happening reasonably and biologically. And it sounds like you respect that of the body and are able to sort of engage therapeutics and schedule those so you're working with the body's mechanism.
Yes.
Like you said, if tumor cells die, they need to be detoxified from the system.
Absolutely.
And that takes time.
It takes time.
Yeah. One of the things I really wanted to talk to you about, especially regarding cryotherapy and your use of the immunotherapies as embolization therapies, is the abscopal effect.
That's a great statement, Dr. Rubin, because one of the reasons that I do what I do is not only to go after the primary tumor. Some patients come to me, they have just a single primary tumor. Other patients come to me, they may have multiple tumors in one organ system, or they may have metastatic, which means that that primary tumor has gone outside that organ system and gone to other places. So one of the reasons I love that cryoablation with the immunotherapy is they've got their own personalized vaccine.
That's huge.
I mean, it's huge. And then you're putting an immunotherapy drug that's either activating the T cells or they may have that specific receptor. When you kill that tumor and you have those antigens released, theoretically, it's supposed to go out so we'll just use breast as an example. So you have invasive ductal carcinoma. Okay, so it's an invasive kind of breast cancer and it's gone other places. When you create that immune effect and it's driven back into the bloodstream, the way that activity happens, it's going to go out and search and destroy any other cancer cell that looks like the primary. And that's the beauty of doing this, because now your immune system is activated. It's on alert. It's on alert, and it's like, hey, there's an invader, there's a trauma going on, and my job specifically is to go out, search for it and then destroy it. So it's not just the primary, it's looking for, so that's considered macroscopic,
Okay.
but it's also looking for the microscopic.
Absolutely.
And I always like to use this analogy because I was prior military. I always think about like the snipers.
Well, tell us.
And,
Yeah.
like, so with the snipers, what can they do? They're really good at being quiet and waiting for the enemy to come out. So they can stay quiet for a really long time.
Like a cancer cell can stay dormant for years.
Correct. Cancer stem cells, they can just remain, they can be very quiescent. And then you're like, okay, the coast is clear. I'm just going to go out in the street and do whatever I want to do. Mm-hmm. And then that's when the snipers get you. It's the same analogy with the cancer stem cells. It comes out, it's no longer quiescent, and it goes after the rest of your body like a vengeance. So doing this form of cryoablation with the immunotherapy. So cryoablation in itself is a form of immunotherapy. Now add an immunotherapy drug and you have got a longer lasting personalized vaccine that's not just lasting for 30 days, 60 days. It's now lasting for 180 days.
You say personalized vaccine, and it's a wonderful term. For our audience, just to be very clear, it's typically a cancer-based vaccine is when they take white blood cells out of the body, a piece of the tumor, they commingle it in the lab,
yes,
change it around a little bit, and then re-inject it in the body. Expensive, complicated, subject to complications. The cells may die extracorporeally. It's difficult. What you're talking about is not that. You're talking about doing it at the site in real time, right then and there, inside the body. So it's going to work. It just is an immune personalized vaccine.
It's a personalized immune vaccine. And then what I wanted to bring up is one of the reasons that I love doing what I do and working with other like-minded practitioners, healers, is that I always tell patients I'm not an ADD practice. I do what I do best, that I'm formally trained in, and then I refer them to other practitioners that are supportive of the body. So it's true. I mean, we have to have wise lifestyle choices. We have to be supportive of the immune system and biochemical, physiological, even as extensive as detoxification. So the reason I like to work with the integrative doctors is that they take on that role where they'll give you the systemic intravenous therapy that's supportive. So it works in concert. It doesn't work against. It's all synergistic because the body was intended to heal itself. And we just live in a chronically toxic world.
Yes, us naturopathic oncologists call that the vis medicatrix naturae, the healing power of nature. I'm glad you brought that up. But because that, even though it's one of our high precepts, it is a ubiquitous notion throughout all of medicine. It's where medicine is at its roots. You mentioned microscopic disease.
Yes.
Stuff that we can't see, that you can't see on scan. Sometimes it's really difficult to even see on a typical lab test, like a typical tumor marker,
right,
like a CA27, 29 for people with breast cancer, a CEA for somebody with breast, lung, or colon cancer, even prostate cancer. Those are the typical tumor markers. Well, you and I have talked quite a bit about the use of circulating tumor cells and helping to detect what we would consider minimal residual disease. And some of those circulating tumor cells that have been recovered are considered cancer stem cells. You and I have had the discussion about how cells that were once what we call epithelial in nature, or residing in a very particular organ, living there, mature, actually become immature. That's one of the facets of cancer. One of the notions is their de-differentiation, finding their way into the bloodstream to become a metastatic deposit.
Right.
And those that can be resistant to conventional chemotherapies or conventional radiotherapies. But what you're talking about is with the personalized vaccine approach through cryotherapy and embolization using other immunotherapeutic drugs, we have our immune system. We're engaging the immune system to go and seek and destroy those. And we're looking really towards durable activity.
Right, and then I always tell patients too, I'm not the end-all be-all. So like I said, I do what I do best, but we have to follow these patients closely because we are looking at that microscopic. And I think that's where patients get really misled.
Okay.
And I have to tell them, I'm going after the tumor. I'm going after what I can see. I wish I could go after what I can't see, which is microscopic. But that's where you come in because you're following those patients. You're looking at the cancer markers. For example, like I know that I'll run it before I even do a procedure because I want to get a baseline. And so like when you said breast, so with breast you have CA, cancer antigen 15-3 or 27-29. That's typically breast. But for whatever reason, some tumors don't elicit those cancer markers. They elicit other cancer markers such as colon cancer, CEA, or CA 19-9, which is usually pancreatic, liver, CA 125, which is ovarian or uterine. Okay, so I think it's best to run all of them, and I know some people are kind of swaying, away from that, but I think it's important because the thing that we want to do is to be able to pick this up early, even if we see a slight bump.
Yes, absolutely.
Okay, so if you just go, oh, you know what, the CA 15-3, CA 27-29 with breast, it's normal. We're just, we're not going to check that anymore. But how do you know when those microscopic cells then get fed somehow and then they accelerate in their process?
So you'd be looking for a trend?
I'm looking for a trend, yes, because we want to stay on it. And the thing that's disappointing for me is that I feel like, myself, my colleagues have let patients down because the standard of care is, as you know, surgery, chemotherapy, radiation therapy. Interventional oncology is another tier, but I just know that they'll come to me. And maybe 3 months later, 6 months later, a year later, even 5 years later, they're like, but doc, I thought I was cured. I had the surgical removal of it. They told me to do chemotherapy for the systemic approach and some radiation. So we lead them to believe that they're good to go now. They're quote unquote cured. And it leads to, a false system where they're good and they may then fall back on their old lifestyle choices. Right. And when I say lifestyle, it's not just nutrition, diet, it can be the spiritual component with faith or whatever.
Psychosocial
and then,
aspects.
Psychological, mental, working out, getting to that place where all those systems are working together synergistically. Because they can fall back and go, well, I'm gonna have that sugar high now, or whatever. And I always tell patients with cancer, you can have a party, one meal, 1 week,
once a week.
Once a week. Yeah. Okay, pick it.
It's a vacation.
If it's really aggressive, you may only get your party once a month.
Right.
Okay, because you want to live life to the fullest. But you also want to keep in mind that you've got to keep those cells revved up and vibrating at a frequency of healing and not death. So I've got a question for you. How do you deal with some patients that they're looking at their cancer markers, they're looking at circulating tumor cells, they're all trending down, they still have the tumor? We'll use breast again.
Okay.
I've had a bunch of patients. They're like, doc, I'm going to hold off because my cancer antigens are going down. The numbers are all trending down. I think my cancer is going away. I don't want to push anybody into anything. I always tell patients, look, my job is to lay everything out on the table and give you really a well-informed consent and give you all the choices that that you may not even realize you have. But I feel like it's really dangerous because the patient still has a tumor there, yet because all their numbers are trending down, somehow in their mind they think my cancer is going away.
Well, and maybe it is going away, but it's not away. And so like you said, our job that they're hiring us for is to educate them, to be the experts, and to explain things so that they understand what their choices are and they can make an educated decision. And in doing so, if we have a patient who sees that their cancer markers are going down, the circulating tumor cells have gone to zero, and maybe when they feel their tumor or on imaging it looks a little bit smaller, that's all good news. But
it is.
What I usually say is this is a really good time for us to act. We've sealed up everything, it's not growing, the immune system looks like it might be active, the physiology of the body is no longer as supportive of the tumor as it was before, and the circulating tumor cells, which maybe were 6, are now 0, which means you have less chance of new metastatic deposits or metastatic deposits. This is the time to act, and I think one of the things that they're missing is that what they're enjoying now in terms of decrease in tumor size and activity may actually take a turn for the worst if the tumor, like you said, can have a mind of its own and become resistant to whatever treatments, and then it's hard to regain that.
Right.
So that sounds like an optimal time for them to act and just finish it off and be as done as they can be.
Well, I'm really glad that you answered that, because that's how I was thinking, is that this is a perfect opportunity, and then continue on with the supportive therapy post-procedure. And like I said, I don't do that, but I send patients to practitioners. That's their area of expertise.
As a naturopathic oncologist, I have often said, and publicly, and it's been published too, that I really don't think that the therapies that I use are as good at killing tumor as a lot of the conventional therapies out there, which are designed to kill tumor. But the regard that we have for the human physiology and the whole rest of sort of the anti-cancer systems and the strength and vitality, and that's really where there's a huge richness for naturopathic oncology, and it's why we're so synergistic in working with patients.
Absolutely, I agree.
Wonderful.
And I hope the whole world gets that way someday, because it's a beautiful thing to see people improve. And I can't say I can cure cancer, but I can say my goal is to reduce the tumor burden where it's non-existent or put you in a chronic dormant state.
And you're doing
forever.
A wonderful job. What I really appreciate and why I enjoy referring patients to you, not only because we can communicate and patients like that and understand that their doctors are working together, but your thought patterns and how you can put complex therapies together to make them even more complex, but in a simplistic way for the welfare of the patient and through physiological response mechanisms, which keep them less toxic, more vital, and more able to then fight on their own.
And it's really interesting because a lot of these patients, you'd never even know that they had stage 0 or stage 4. I have a patient who just had her 60th birthday, and she's been fighting cancer for about 5 or 6 years. She had a large tumor burden, went to a birthday lunch, and her friends all said, "You look great." And she was cute because she's like, "What did I look like before?" And she had a large tumor burden. We did the embolization. We did a couple cryos because it was really big tumor burden. And we're doing we did the intratumoral immunotherapy injection. And then we're doing the IV immunotherapy every 3 weeks. So it's all synergistic. Here's somebody who's walking, talking with stage 4 and looking just illuminating. You would never know. We're not taking these patients to chemotherapy, radiation, where...
Not that we're opposed to that.
No, we're not. I'm not opposed to it at all, because I tell patients with chemotherapy, if you've got a large tumor burden, you want to reduce that amount of tumor burden so that I can do what I do best and you can do what you do best. So there is a place for it. I'll never say there's not a place for it.
Absolutely. I am like-minded. We are absolutely believe in the integrative model. As a naturopathic oncologist, I find that I practice very comfortably there and intercommunicate within the greater context of the oncology community here in the Phoenix area as a whole. We're just talking about a specific sect of patients that either don't want surgery, can't have surgery, or that this may be a better option for some, well-documented instances.
Well, and also today too, I always feel like I'm part of the voice of truth. So patients will come to me and say, hey, doc, what do you think? And I can speak to them in a simplistic form. So like patients who are triple positive or HER2 new receptor positive, I say to them, okay, you see that door right there? Think of that as a receptor, okay? Now, if the computer over there is the command center that's directing, giving commands outside that door, and they're giving an abnormal communication, like grow, 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 grow. What I say to them is, you want to do something that's going to block that HER2 new receptor. So, we do intravenous Herceptin, Perjeta. Now there's a new oral medication called Nerlynx. What I say to the patient is that's targeted therapy. Don't you want to lock that door so that the commands that are being sent to, the major command center are not miscommunicated, that now it's saying, don't grow, die, instead of grow, grow, grow. So again, I feel like I'm the voice of truth. So patients who would normally only want to do complete alternative therapy are now like, oh, wow, okay, you've got a point. So this really is targeted therapy for my tumor. So it's really synergistic in a positive way and hitting the cancer from many different perspectives. That's the goal, is to hit it from many different perspectives.
Dr. Stryker, the work you're doing is extraordinary. So many people out there are looking for something like this, and it's wonderful for me to be able to contact you and co-manage patients with you and refer them to you. And thank you for being here and sharing your work and your thoughts and your visions with us for the betterment of people with cancer.
Well, thank you, Dr. Rubin. It's really a pleasure to work synergistically with you. Doing this together is we're gonna clean up this mess.
Awesome. Thank you.
Thank you.